I will now introduce our next speaker. It's Dr. Eugenia Socias. She is an associate professor in the Division of Social Medicine, Department of Medicine at the University of British Columbia, and a clinician scientist and the clinical research program lead at the BC Center on Substance Use in Vancouver, Canada. She will be speaking with us on clinical considerations for responding to synthetic opioid use.
Good afternoon, everyone, and thanks for the invitation to talk in this session. I should say that when I was asked to talk on clinical considerations for responding to synthetic opioid use, I guess based on having been living in North America for so many years, my bias was to immediately think on fentanyl, but now after listening to Angela's talk, I acknowledge that I should probably think about other synthetic opioids like tramadol, which is a huge problem in other parts of the world. So apologies in advance, but my talk will largely focus on fentanyl.
Sorry, can I just ask that we have the speak? Do you want the?
No, I think it's fine, yeah.
Yeah, like that, it's okay.
I'd like to start by acknowledging that I live and work on the traditional and ceded homelands of the Coast Salish peoples in Vancouver, Canada. These are my disclosures, and in addition to this potential financial conflict of interest, I should say that although over the past 8 years or so I've been working in substance use research, my clinical background is in infectious diseases. These are the topics I would try to cover today, and my hope is that after these 20 minutes or so, you will take away a good understanding of the unique pharmacological properties of fentanyl, how this may impact our pharmacotherapy choices, as well as other considerations when providing clinical care for people using fentanyl. So let's start with our first question. What makes fentanyl distinct from other opioids? As I'm sure all of you know, and Angela also briefly talked to this, opioids are a class of drugs that mimic the action of endorphins, which are endogenous opioids. So we have opioids, which are natural opioids that can be found in the opium poppy, such as morphine and codeine. We have synthetic opioids, such as methadone, fentanyl, and tramadol, which are chemically made, and semi-synthetic opioids, such as heroin, oxycodone, and buprenorphine, which are made from opioids that can be chemically processed. There are several opioid receptors, but the mu-opioid receptor is the one that receives the most attention and is responsible for producing analgesia as well as respiratory depression. One important pharmacodynamic consideration to remember when we talk about drugs is their efficacy. Here, for example, you can see dose response curves for a full agonist, a partial agonist, and an antagonist of the mu-opioid receptor. Methadone, morphine, and fentanyl are full agonists, meaning that they will fully activate the receptor with increasing efficacy as you increase the dose. Buprenorphine, on the other hand, is a partial agonist. So as you can see on the figure, at lower doses, it causes similar effect as a full agonist with increasing efficacy as we increase the dose. However, there is a point that is here after that even if we increase the dose further, the effect does not increase. This is what we call the ceiling effect. And one advantage of the ceiling effect is that it's less likely that it will produce respiratory depression than full agonists. Finally, naloxone or naltrexone are antagonists, meaning that they don't produce any opioid effect when they bind to the receptor. In addition to the efficacy of a drug, another pharmacodynamic concept that we need to remember is the affinity or potency of a drug, which refers to the strength by which a drug binds to a receptor. For example, as you can see on the figure, fentanyl is the most potent of these three opioids. So we need less drug to achieve the same effect. And it's also a full agonist. It has the same maximum activity as morphine. Buprenorphine is also more potent than morphine. However, it has lower efficacy as it is a partial agonist. So now that we have briefly reviewed the general pharmacokinetic and pharmacodynamic characteristics of opioids, what are the characteristics that make fentanyl unique? First, there is no correlation between fentanyl's potency with measurement of efficacy. Second, it is highly lipophilic. And third, it has the potential to cause respiratory muscle rigidity. And I'm going to expand a little bit more on each of these characteristics. So as mentioned a few minutes ago, usually the potency of a drug is a function of its affinity for the receptor, but this is not the case for fentanyl. As you can see on the figure, fentanyl has similar affinity to the mu-opioid receptor as morphine. However, when we look at its potency, and as you can see on the second last column, depending on the study, fentanyl is between 40 to 160 times more potent than morphine. And a possible explanation to the difference in potency between morphine and fentanyl, despite their similar binding affinity, is their different lipophilicity. Indeed, fentanyl's higher lipid solubility compared with many other opioids allow for this drug not to only concentrate around the mu-opioid receptor, as you can see on the pathway 2 on the figure, but also to make it more likely to enter the mu-opioid receptor via the transmembrane domains, which you can see by the 1 and 3. The high lipophilicity of fentanyl also explains its rapid crosses of the blood-brain barrier and consequent fast onset of the CNS effects. Finally, the rapid distribution into lipid-rich tissue with a slow return to plasma further explains fentanyl prolonged activity despite a relatively short half-life. Finally, and again due to fentanyl's high lipid solubility and consequent rapid permeation of the brain, it has been suggested that it's more likely that fentanyl will produce muscle rigidity than other opioids. Although this rigidity can be seen in any skeletal muscle throughout the body, the sudden onset of laryngospasm, together with severe rigidity of key respiratory muscles, can produce what is typically called the wooden chest syndrome, which can lead to a rapid respiratory failure. So how the unique pharmacological characteristics of fentanyl actually translate into our clinical management of people using fentanyl? As all of you probably know, medications are the standard of care for the treatment of opioid disorder. Available medications vary in settings around the globe, and it may include extended-release naltrexone, buprenorphine, both the sublingual and the injectable formulation, and methadone. In Canada and some European countries, we also have access to off-label slow-release oral morphine, as well as injectable diacetylmorphine, as more intense approaches for people who have not benefited from oral options. Individuals with opioid use disorder may require different interventions at different times and move along the continuum based on the severity of their opioid disorder, their goals, and their context. It is important to remember that in addition to pharmacotherapies, we should be offering everyone evidence-based harm reduction interventions, such as education, access to injection supply, STBBI testing, access to supervised consumption sites, naloxone kits, and drug checking services. Some general principles to remember when using medications is that each of them requires a different induction process, has its unique pros and cons, and that patients may respond better to one or to other medication at different times. As such, ideally, all medication should be available for every eligible patient. Also, it's very important that I'm sure everyone in this room knows, opioid disorder is a chronic relapsing condition, so typically requires longer-term and indefinite treatment for better outcomes. Also, just a quick reminder that although detox services can potentially be an important first point of contact with health services, detox alone is associated with higher rates of overdose, relapse, and HIV transmission. And for these reasons, detox is not recommended as a standalone strategy. I don't have time to review each medication in detail, but generally speaking, what do we know about treating opioid disorder among people using fentanyl? To be honest, not much. Indeed, most clinical trials have been conducted among people using heroin and a little bit among people using prescription opioids. And also, most of the studies, including observational ones, predate the upsurge of fentanyl in the unregulated drug market. So what do we know? Is there any evidence at all that could guide us in our clinical management of people using fentanyl? That actually a very important and relevant question led us to start a systematic review where we are looking at the effectiveness and safety of pharmacotherapies for opioid disorder among people using fentanyl. The review is ongoing, so unfortunately I don't have results to share with you today, but as you can see on the slide, the evidence is not only very limited, with only 4 clinical trials and 13 observational studies that have looked into this topic, but also, generally speaking, as you can see on the table, the evidence is not the best, the quality of the evidence. So, acknowledging the limitations of the available literature and going back to our initial question, what do we know about treating opioid use disorder among people using fentanyl? Well, for starters, there is evidence to suggest that the mortality benefits of medications for opioid use disorder not only remain in the fentanyl era, but have actually looked greater. Depicted on the slide, you can see the mortality, the standardized mortality ratio of people on and off OAT in British Columbia between 2010 and 2018. Those on OAT are shown in purple, and those off OAT in yellow. And as you can see, the mortality among people who were not on treatment started to increase after 2014, when we started to see an increase of fentanyl in the illicit drug supply. However, the mortality risk among people on OAT remained relatively stable during the whole study period, which actually translates into even larger protective effects of pharmacotherapies against mortality in the fentanyl era. Second, there seems to be evidence to suggest that people using fentanyl may have similar methadone outcomes than people using other opioids. This is data from a study that was done in a methadone clinic in Rhode Island between 2016 and 2017. And as you can see on the table, this study did not find significant differences in rates of retention, abstinence, or relapse at 6 months between patients who presented at intake with positive screens for fentanyl only, for other opioids only, or for both. Third, this is data from another retrospective study of around 250 patients who were initiating office-based buprenorphine in Boston between 2016 and 2017. And as you can see on this graph, buprenorphine outcomes also seem to be similar in terms of retention and abstinence rates among people using fentanyl or heroin at intake. That said, the risk of precipitated withdrawal with buprenorphine among people using fentanyl appears to be higher. For example, this is a cohort of more than 1,100 individuals who entered addiction treatment and self-reported fentanyl use. And as you can see on the table, people who started buprenorphine within 24 to 48 hours of last fentanyl use had 3 to 5 times increased odds of precipitated withdrawal. However, this higher risk of precipitated withdrawal was not observed among people who started buprenorphine after 72 hours of last fentanyl use, or among people who started methadone, regardless of the timing between methadone start and last fentanyl use. And what about naltrexone? Well, this is a second analysis of choices, an RCT that randomized around 100 people living with HIV, with opioid use disorder, to extended-release naltrexone or treatment as usual, which could include either buprenorphine or methadone. And in this study, the investigators found that participants with baseline positivity, which is shown with the red line, were 11 times less likely to initiate treatment than those who were negative for fentanyl at baseline, that you can see on the top figure. In contrast, there was no evidence that fentanyl impacted the initiation of treatment as usual, as you can see on the bottom figure by the overlap of the red and blue curves. Importantly, once treatment was initiated, there was no evidence that fentanyl use negatively impact any treatments in terms of retention. More recently, there started to appear some evidence for the use of extended-release buprenorphine among people using fentanyl. For example, this was a post-hoc analysis of an RCT that compares sublingual buprenorphine versus weekly or monthly subcutaneous injections of extended-release buprenorphine. And in these two analyses, the investigators look at the effectiveness of these two medications among participants with or without fentanyl use at baseline. And as you can see from the flowchart, retention at 24 weeks was similar between the subgroups, both of medications as well as fentanyl use or non-use. And safety was also similar between the groups. In terms of opioid use, on the left, you can see UDS results throughout the trial for sublingual buprenorphine and extended-release buprenorphine among people who were positive for fentanyl at baseline, and on the right, UDS results for people who were negative for fentanyl at baseline. And as you can see, In this graph, both sublingual and injectable buprenorphine were at least somehow effective in suppressing opioid use, with around 1/4 of the samples being negative for opioids during the trial. However, these rates were lower than among negative participants who were negative for fentanyl, who had a rate of around 34%. One interesting finding of the study is also that, as you can see here, although in earlier week of the trial, the curves for extended-release buprenorphine and sublingual buprenorphine overlap, after around week 5, those patients the participants who were receiving extended-release buprenorphine had higher rates of urine samples that were negative for opioids, which actually may suggest that the extended-release buprenorphine may be more advantageous than sublingual buprenorphine among people using fentanyl. The last pharmacotherapy for which we have some evidence of effectiveness and safety among people using fentanyl is slow-release morphine. Specifically, this is data from an emulated trial that is currently under review that included approximately 4,000 episodes of either methadone or slow-release morphine in Vancouver between 2018 and 2024, so right in the midst of the fentanyl opioid crisis. When we look at discontinuation, our primary outcome, we saw that treatment duration was very, very short for both arms, and that over 90% had discontinued their assigned treatment at 12 months. However, as you can see by the data on the slide, methadone was still associated with a small relative advantage over slow-release morphine. The other outcome I wanted to show you today was mortality. And as you can see, overall we had 119 deaths over the 1 year of follow-up. And importantly, all except 2 deaths occurred when people were off treatment and there were no differences between arms, emphasizing again the importance of retaining people in treatment to prevent mortality. So if you remember a few minutes ago, I alluded that buprenorphine and methadone outcomes were similar among people using fentanyl or not. However, in these last two slides, I actually said the opposite. So why the discrepancy? Well, the first 2 studies that I show at the beginning were conducted in 2016, 2017, and these 2 studies, one on extended-release buprenorphine and this one on morphine, were conducted in more recent era. So I don't have the answer to that question, but things that have changed, like the potency of fentanyl in the illicit drug supply, the emergence of other contaminants like benzos or xylazine, as well as also we're seeing an increased co-use of stimulants among people using opioids, all of which could have impacted these discrepant results that we're seeing in this like relatively short period. And that actually brings us to our next question as to whether fentanyl really poses a problem to treating opioid disorder. And what do I mean by that? Well, this is data from this is second analysis of Optima, which was a pan-Canadian pragmatic clinical trial that compared methadone and buprenorphine models of care among people who were using opioids other than heroin, which could include either prescription opioids or fentanyl. And in this second analysis, we found that while the crude odds of OAT initiation was lower among fentanyl-exposed participants, the association became insignificant in the adjusted model. Similar, when we look at treatment discontinuations among participants who started treatment, although survival curves show significantly shorter times in treatment among fentanyl-exposed participants, which is shown by the solid lines compared to those who were negative for fentanyl. Similar to our analysis of treatment initiation, our adjusted models did not find evidence of a negative impact of fentanyl on discontinuation. So again, you may be asking yourself why we're seeing these discordant results between the crude and adjusted analysis. And one potential explanation to this question may be to the characteristics of the participants who were exposed to fentanyl. So as you can see there on the slide, relative to those who were negative for fentanyl at baseline, those participants who were exposed to fentanyl were more likely to be non-white, mainly of indigenous ancestry, to be unemployed or homeless, to be concurrently using stimulants, or to have worse depressive symptoms. And as you probably know, all of these characteristics are associated with worse treatment trajectories among people with opioid disorder, and maybe actually, at least partially, be the ones that are driving the worst outcomes that we're seeing. And finally, at this modeling study from British Columbia suggests, although pharmacotherapies are an important tool in our response to the fentanyl overdose crisis and has contributed to avert many overdose deaths, it is not a silver bullet, and we need a combined approach, including increased access to medications, but also harm reduction strategies, such as take-home naloxone programs and supervised consumption services, among others, if we are going to end this epidemic. So, as you can see, although there is some evidence to support the effectiveness of pharmacotherapies in the context of fentanyl use, this evidence is very limited and many questions still remain unanswered. And probably we won't have evidence-based recommendations for a while. So, what should we do when a patient using fentanyl presents to our clinic? Well, as with every patient, but maybe more than ever, given the limited evidence base to guide our decisions, pharmacotherapy and other treatment choices should be a shared decision between the clinicians and the patients. Also, from what we know, it will be important to take into account the unique pharmacological properties of fentanyl, as well as other clinical and socio-demographic characteristics of people using fentanyl when making this decision. Oh, sorry. just briefly, the last part of this talk will focus on what are some of the additional considerations that we should take into account when providing clinical care for people using fentanyl. As you know, people using fentanyl are at increased risk of overdose, so providing overdose prevention measures is more essential than ever, including education and access to take-home naloxone kits. Unfortunately, we have been seeing increasing reports of unsuccessful overdose reversal with increasing contamination of fentanyl, and usually we may need higher or multiple doses of naloxone given fentanyl's high potency. Also, the window of opportunity for a successful intervention may be reduced. Another challenge posed by fentanyl is that standard point-of-care opioid tests only detect the presence of natural opioids, so we cannot reliably detect semi or synthetic opioids. So if we want to detect fentanyl, we need to add other test strips or use other methods. In terms of harm reduction interventions, the newer kid on the block is safer supply programs. I believe Matt is going to talk about this, and in the sake of time, I'm not going to go into details of it, but just to know that they are very controversial, but the research that's out actually has shown some benefits of these programs. And finally, also that at least in Vancouver, some clinicians are starting to use fentanyl patches as an innovative MUD practice for people using fentanyl. So, yeah, just to conclude, we have been witnessing an escalating overdose epidemic in many cities in North America. There is lots of unknowns, but preliminary evidence suggests that pharmacotherapies are effective, though there may be a need to adjust dosing strategies. Also, finally, that although pharmacotherapies are important, we need a comprehensive response, including harm reduction interventions as well as social structural level interventions, and also that we desperately need more research on novel pharmacotherapies and other harm reduction strategies to address the increasingly toxic drug supply and different needs of people living with opioid disorder. Thank you.